All right, I'm starting the recording now. Hey, this is Travis. I'm filling in for Jeff, who hopefully will join us in a few moments. But I think we'll start with Seth, if that's okay.
Sure.
Sorry, change presenter.
Okay, so this is the first case, and we see a lot of these here. I don't, well, I know why, because they have a kind of a center for it, but not just for CTEPH. So here's a person who presents with months of progressive shortness of breath. The most conspicuous finding, this nodule, but a little bit less of a conspicuous finding is the kind of decreased attenuation throughout the right lung. It is actual. I'll show you the CT. It is real. It's not just rotational. So not the best Western mark sign I've seen here, but one nonetheless. And then here is the PE study that. Whoops. Let me get to the lung windows. I mean the soft tissue windows. And you can see here that there's this very large infiltrative mass in the right main PA extending into the central PA. Also, there's this involvement of the wall of the main PA kind of extending into left PA and getting down towards the pulmonary valve. And then you can see this is expanding the lumen of the vessel, and there you can also here make out the variability in the attenuation, but overall pretty net reduced vasculature in the right lung because of the obstruction, and then these scattered couple nodules. So of course, the history I got was shortness of breath, and I was freaking out, called them up, and I said, I think this guy has a PA sarcoma, and they said, yes, we know he has a PA sarcoma, and I thought that would have been nice if they told us that. But here is so here they do a lot of, UCSD has a big center for CTEPH and endarterectomies, but they also, I've seen a ton of these pulmonary sarcoma cases here. I guess they also do these for sarcomas. They actually have pretty good results. So here the patient underwent a pneumonectomy, and here is the sarcoma from the right PA. They kind of pull it out. They kind of remove the intima and pull this thing out, and this was an intimal sarcoma of the pulmonary artery. And this is about the third or fourth one I've seen in just a few months. And they actually, eventually they all come back, at least the ones that have been here for a while. But I have to say, we had a case the other day. I mean, the life expectancy of these when you get diagnosed is pretty short. It's in the range of months. And most of the people, when I see they finally pass away, it's usually after a few years after diagnosis and surgery. So we'll see how this one does. They often replace the whole main PA and left PA and do a bunch of different things. And so I thought that was a pretty case to start off. And then here's one I got fooled on, which someone showed me. This is actually from before I got here, where another case where it's a very large unilateral abnormality. And whenever I see a big filling defect within just one side, and predominantly in the main PA, I just get worried, and the vessel's expanded, I get worried that there's a sarcoma, and there really was not disease anywhere else. I mean, there was distal obstruction, but in that last case, there was distal obstruction as well. Anyways, they went in, and this guy, they made the diagnosis, I don't know, either by surgery or that this was not a sarcoma. This was just a unilateral massive thrombus. And here you can see they treated the patient, and it actually started to contract and get smaller in size. And then he has findings, and this is about 2 months later, of chronic thromboembolic disease. And then here's his path. And it looks very similar. This is just a canalized thrombus. And this was just all thrombus. But, I have to say, most pulmonary emboli that I've seen have not just had, this is the only case I think I've seen where there's just a massive Goomba sitting in the left main with distal obstruction and nothing else anywhere else. And this was just a PE. So kind of it.
Did they ever have DVT, or do you think this, again, was one of those in situ thrombi that has formed? I know we always have this question.
I'm not a huge believer in the in situ thrombi
Really?
in most instances, but this patient had known DVT.
No, okay.
Yeah, no, that was what for me, I was showing this like, oh, that's a sarcoma. They're like, no, this dude's got known big DVTs, and this is a PE. And I'm like, okay. And then they showed me the follow-up, and yeah.
Does this guy have a Western marks too? What is his long continuation?
I have to pull the chest X-ray. The CT is a little too motiony. He does have I have to say the vascular pruning. Let me see on the more chronic one.
He's pretty well compensated too. He didn't have right heart dilation.
No, he didn't. Even on this one where he's started to really knock out that left lower lobe PA, I have to say I would be even hard pressed to, even knowing that left lower lobe is completely out, to say that there's even any difference in attenuation.
Yeah.
So, anyways, and this was a case that just happened the other day, and I still don't understand the diagnosis. So this is a 19-year-old who has this, these soft tissue mass with these extensions, maybe they're nodes, extending into the mediastinum around the superior pericardial recess, around the main pulmonary artery, aorta, kind of in the subcarinal region, infiltrating around the wall of the left atrium. And if you measure the attenuation anywhere, it never gets above, and you can see along the intratracheal septum, it never is above 30 Hounsfield units. And it's kind of like this infiltrative appearance. And I looked at this and I was like, oh, I bet you this is going to be, and just how it looked, mostly fluidy, and it's this infiltrative thing, but it doesn't look really aggressive. I was thinking it's going to be some form of lymphangioma or something. So here they did a bunch of biopsies, which were non-diagnostic, and then they actually did a more invasive biopsy. And this is the path they got, and I still have doubts about this. So they called this a plexiform neurofibroma, and said it wasn't even a question. I mean, it was absolutely classic for plexiform neurofibroma. I have a lot of things in my differential diagnosis for infiltrative mediastinal mass, but plexiform neurofibroma isn't on that list. But I don't know has anyone ever seen anything like this?
In the retroperitoneum, yes. Yeah, I've seen.
You have really? Okay.
Yes, an infiltrative one that I thought was going to be lymphoma or some lymphangioma or something. Yeah. But
right, so lymphoma, right? Classically, you're like 19-year-old infiltrative mass, the lymphoma, but it's kind of fluidy, so it's like something strange, lymphangioma. And so you've seen the retro. I'm like want to call it the pathologist and say you're sure, but
okay, I will. I'll
they basically say it's like the most. Okay, because they say it's like the most classic, neurofibroma, plexiform neurofibroma, and he has no other signs of neurofibromatosis, which is just odd. So, anyways, those are my three cases, and I still owe you guys a bunch of cases. It's hard to get them off the thing here, but I promise to get them to you guys.
All right, David, do you have anything?
I have a mouthful of food here, but in a second I can show follow-up for one of the cases from last week.
Okay. I'm pulling up, let's see, I'm trying to find this case that a friend had sent me, and I'll show it to you, Seth, when I can get it. David, I'm going to give you control here if that's okay. Brent, I don't know. Brent, do you have anything?
I'm kind of off site, so I don't have
okay.
Anything, but I did have a question for Seth. Seth, do you think there's some, looking at the skin there, oh, sorry, I think you switched.
Oh, sorry, I'll switch it back.
I was just wondering if there were some subtle neurofibromas in the skin that were just not very well developed yet. I don't know.
No, you may be right. I mean, I didn't read this case. There are little, now that I'm looking, this was, I was reading the plain film, and after his surgery, he has complete left lower lobe or complete left lung collapse after his more in-depth mediastinal surgery. But you're right, there are little, like there's a little guy here. Maybe there are some more, but that's a good point. Maybe there are a few little things.
Because I was thinking, whenever I see neurofibromas, I always look in the mediastinum because they're often those along the mediastinal nerves, and when you showed it at first, I was thinking, maybe that's along, the course of
Silicolaryngeal.
Right. So, I don't know, because I was looking at that location. They're often, I think more than are really recognized, they're often small neurofibromas that are mediastinal, that are tubular, that follow, that occur in the upper mediastinum. So
and that's what it turned out to be. They must be just along, as you were saying, exactly those. And they are tubular. It's not this is an outside study, not very thin cuts, but so I think you're absolutely right.
But I've never seen one so infiltrative, though.
Along the the phrenic and the recurrent laryngeal. Yeah, I just and up here it would be fine. It's just this weird stuff down here around the pulmonary veins. I'd almost believe Erdheim chest are more than
right
a neurofibroma. It's just so odd.
All right, I'm going to take control for 1 second and then give it to David.
Sure.
Let me. I found this. This was from a former co-resident of mine, Vilas Shetty, who's now at SLU, and this is the case he sent me a couple years ago. Of course, I never would have guessed in a million years that this was a plexiform neurofibroma, but that's what this turned out to be. This entire thing. It actually went up into the middle mediastinum.
Yeah, and it looks similar. It has all the, it's low density, has all the vessels course, the low vessel, or the vessels coursing through it without obstruction.
Yes.
That's wild.
Yeah. So, all right.
Okay. Lesson learned. Added to the differential diagnosis. Number 15.
All right, David, I'm going to make you the presenter.
Okay. This is a case I showed last week of a 26-year-old guy who turns out was a occupant or a guest of the King County Jail at the time that he had this CT scan. And the reason he had a CT scan is that he had a positive PVD. He had received BCG vaccination. He's from El Salvador. There were some abnormalities on a chest radiograph that I'm trying to get that was done in the middle of the summer that showed bilateral pleural effusions. So at this point, we don't have pleural effusion anymore, but we do have these interesting pleural findings. And I showed this last week. We have these faint calcifications here along the pleural surfaces, a big one posteriorly here on the left, these lentiform lesions. There's some brighter calcification along the periphery of this. The lung looks pretty unperturbed. There are a few little bands associated with these pleural things. There's a deposit here along the pleura. For a 26-year-old, you're not expecting pleural plaque. And I was wondering, except we have seen some Mexican patients who were live in a village where there's a natural exposure to an asbestos-like mineral blowing in the air. And those people have mesotheliomas by the time they're 30 frequently. So we've seen a few of those people. This person does have a calcified granuloma down here, so that might be TB. But coming from El Salvador, I don't know whether they have cocci there. A Mexican person would be exposed if they're from the Sonora Desert to cocci and could have a calcification like this from cocci rather than TB. So when I was showing this last week, the best I could come up with was some unusual pleural plaque. Then Howard really noticed that there are two different colors of calcification here. There's this more milk-calcium appearance here, and then the denser calcification at the periphery. So I just, based on what Howard said, I searched for milk-calcium and pleura, and it turns out there is an article about this, milk-calcium pleural collection CT findings. And in this article here from our Korean colleagues, there are some very similar findings. For instance, this case down here, except this one had a fluid level in it, which more nicely shows the liquefied part of the milk here. But again, an elliptical deposit here, very bright on these ancient CT scans. And they attributed this, they said that their cases were in people who'd had previous pleural inflammation. So with the history that I just got this morning that this fellow had had pleural effusions earlier this summer, I'm trying to get those radiographs from the jail, which is a bureaucratic nightmare, but hopefully is underway. And this is probably, in this guy, the residuum of some remote empyema or other pleural inflammation. So milk of calcium was the key. I think Howard mentioned that, by the appearance and stuff like that, and that led actually to this article that shows similar findings. So, my best guess last week was some sort of early exposure to asbestos and unusual pleural plaques, but now I think this milk of calcium from remote inflammation is a better idea. And the people who attended last week, nobody had seen anything like this before. So we've got some new people in today. Has anybody in the current group seen a case like this before?
No.
Not really.
Not sure what else to say.
Okay. So
yeah, it looks more like pleurodesis.
That's what I was wondering, whether there was no hint that he'd had pleurodesis. And usually, that's more irregular. It's not as smooth as this, and there's a lot more pleural thickening associated with that. This person doesn't really have very much pleural thickening here at all. And the pleurodesis, usually they've got pretty ragged looking pleura. So yeah, I thought about that last week. Could this be talc? But I would expect a lot more pleural thickening in the presence of talc. Okay, that's the follow-up that I have, and I don't have any other cases ready to go at this point.
Okay. All right, I'm gonna show some, and Jeff is on now, and then I'll give him control later. All right, my favorite case that I've seen in quite a while here, and this one has a long story to it, but I'll give Seth a chance to redeem himself for the plexiform neurofibroma, since maybe if somebody has seen this, he has. So this was a case last month, and a colleague asked my opinion on it. And it's a 30-year-old man, and his chart, his electronic medical record was completely empty. And the only word we got for this study was research. And so that is the clue. And this is the study. And so my colleague asked me what I thought. And I don't know, first guess, of course, with this kind of look, guessing that he's not acutely ill if he's an outpatient with research, history of research, maybe lymphangitic carcinomatosis. It's not that great for it though. It's very, somewhat regular septal thickening, not a lot of peribronchial wall thickening, and really just an impressive crazy paving pattern with a lower lobe predominance.
And nothing induced on him?
And there's nothing in the mediastinum. So then I was like, well, if it's research, maybe he's got idiopathic pulmonary hemosiderosis or something. And then, I don't know, 6th or 7th on my list, I started to tell a story about how when I was a resident at Mallinckrodt, that Thomas Franquet was a visiting professor and gave a case conference. And since I was the one going into chest, I got to take the first case, which looked exactly like this. And it was something nobody had ever thought of or heard of. And of course, I remembered it from that time since, but I'd never seen a case. Any guesses?
Oh, I don't know. Lymphangiectasia, Niemann-Pick, some weird storage disease.
Yeah, Seth. Maybe you with AFIP.
Are the bones normal?
Yeah, everything else is pretty normal. His spleen and his liver might be a little borderline big, but
Oh, dude, I have.
Yeah.
If it's something no one's ever heard of, I have no idea. I mean, yeah. I would come up with your standard differential.
Well, Jeff,
it looks like something lymphatic, though. I would wonder about, Gorham syndrome or lymphangiectasia or something like that.
That's why I was wondering about the bones, because usually in Gorham's you get this stuff in the soft tissues and bones.
Well, Jeff,
but I agree. Some sort of
right.
lymphatic malformation.
Jeff was right. This is Niemann-Pick, and this is what, and I think this goes to the value of having to take cases in unknown conferences, because I never forgot it after Tomas showed a case, and I just kind of said, well, I've seen a case of Niemann-Pick that looked kind of like this, or some sort of deposition, and we were able to dig up a history and a scan note that this was a research study for enzyme replacement for Niemann-Pick. So
Yeah, I think I have another case. I know I have another case. I think it looks pretty similar to this. But anytime I see, it's funny. When I talk about septal thickening, sort of a septal pattern, it's in my zebra bucket of Niemann-Pick and other storage diseases.
So this paper from 10 years ago or so, this is at Mount Sinai, and I guess all these patients get referred here. So Niemann-Pick, not to belabor this though, but it's sphingomyelin deposition. There's different types. Type B are the patients that live into adulthood. Some of them have ground glass, but most of them look just like this patient does, as you can see here. And so it's something, it is a zebra on the list. This paper concluded though that their CT findings and severity findings don't really correlate with symptoms. They usually have few respiratory symptoms. They end up more with hepatomegaly, splenomegaly, issues with organ deposition of these sphingomyelins in other organs. But it's such a pretty pattern though, and you can just imagine some sort of deposition, mostly within the lymphatics, I guess. Here is his radiograph here. But that got me to dig up a couple of other cases. I went searching through our teaching file to see if it's ever been seen. And again, this was a patient with a history of Niemann-Pick, and this was just done to evaluate for elevated liver enzymes. It's interesting, they thought in this case, because this was just an abdomen pelvis CT, that his adrenal glands were enlarged as well, which they thought might be due to sphingomyelin deposition there. But on the abdomen pelvis CT, this was just kind of blown off as pulmonary edema, and they never said anything else about it, but clearly looks very much the same as the other one. His heart's normal size, and there's no other findings that really indicate edema. So type B is usually adults, and then I did find one case of type A, which I think is this one right here, which is a much more severe infantile form, and these patients usually have neurological issues from an early age. You can see this is when this patient was 6 years old. Very similar findings in the lungs, just an extensive crazy paving pattern. And this progressed, and this patient ended up, unfortunately, dying. This is when they were 10, and they may have had some acute fluid on top of that. But this was another more severe case of Niemann-Pick disease. So
I don't think I've never seen a case. Yeah.
So, Jeff was at Cleveland Clinic, and they have a big referral population for this. So, Jeff, is that where you saw your cases before?
Yeah, actually, I have 3. I'm downloading them right now, so I might get to, if there's time, I can look at them and show them to you guys. But
okay,
I found 3 on my files.
Travis?
Yeah.
I just want to take issue with your terminology.
Please do.
This pattern is septal thickening.
Yeah.
And I reserve crazy paving for a ground glass abnormality with overlying reticulation. And this case does show both ground glass and reticulation. So crazy paving is okay here. But that last case you showed, or one of maybe the third case you showed, was reticulation, but no ground glass. So I would just call that septal thickening.
Yeah. In this one?
No, this one I think is ground glassy too, but I think it was the one before.
Okay, yeah, let's take another look. Yeah, you're probably right. I have no problem with you taking issue if I want it to be precise. Let's see. Yeah, I mean, you're right. It's mostly just septal thickening. I thought maybe there was a little bit of ground glass. That could just be some atelectasis too, but yeah. But you're right.
I just want to make sure the septal thickening doesn't turn into crazy paving all the time. That's all.
Agreed. Thank you. All right. Let me show this one. This is a nice one. It has a nice radiograph too. And let you look at the radiograph for a second. I think this woman is 80 years old. She's old, has dyspnea, and there are a few findings. Of course, you see in her lungs, she has some more dependent opacities, both lower lobes. But the more impressive finding, I think, and one that can tie everything together, is if you look on the lateral especially, notice how her trachea is deviated anteriorly, and we have filling of the retrotracheal space, and you can see it looks like there's at least kind of wants to be an air fluid level there. And when you look back at the PA view, you've got manubrium in here, but there also maybe a separate air fluid level. I don't know, maybe right here is where you see it, but you have this extra gaseous distension here outside of the course of the trachea. And then it kind of fills in and obliterates the azygoesophageal recess as well. And so sure enough, this is a lady that has a history of achalasia, and you can see her impressively dilated esophagus. But what I like really about this case too is the fact that the lung abnormality is crazy paving here.
Yeah.
So, yeah, so she's been taking a lot of mineral oil and other lipid, potentially lipoid pneumonia substances by mouth, trying to help with her issues with indigestion and clearance. So I guess we're presumptively treating or thinking that this is a form of a lipoid pneumonia just from her aspiration from her dilated esophagus. You know, none of these areas have true macroscopic areas of fat, but I don't know. Anybody have any other thoughts?
It's aspiration of something.
It's probably mixed stuff, and that's why you see some areas of tree and bud stuff.
Yeah, but I just thought this was we've had a crazy paving theme here recently, so figured I'd show that. So this one, yeah. So right, to clarify, yes, the reticular abnormalities or septal thickening plus the ground glass opacity for the crazy paving, not just one or the other. So, all right, Jeff, do you want to show some?
Sure. I've got quite a few, so I can save some for next week. We'll see where other people want to go. Let's see. Okay, this is a pretty case. This is a nice stuff. It's something we don't see much anymore for pharmaceutical reasons. Can you all see a Röntgengram?
Yep.
Probably. Okay. So this is a liver transplant recipient who developed a febrile illness, and you can see there's nodules in the lung, and CT scan was done, which of course shows nodules, but what we see are nodules with halo signs, probably a little organizing pneumonia in some of these areas, but we'll try to be atolls, but looks good for an angioinvasive infection. This was shown to be aspergillus, which would be the most common, but of course, a lot of other things can look like this. But what's cool is the evolution of this. So here is the follow-up radiograph, and this was about a week later with voriconazole treatment. And you see that these have now cavitated, and several of the cavities contain central structures in them on the radiograph. And we see that same thing on the CT. And Chris used a term I hadn't heard before, but I like doll's eyes. With this, what they call the true air crescent sign, not the monad sign, but the cavitation of these. And it's interesting because it was described in the neutropenic patients after their stem cell transplants, when their counts would start to recover, you would see this. But this patient was never neutropenic, but because of his liver transplant, presumably had dysfunction of his, or reduced function of his T cells. So, but I haven't seen this a lot lately. I mean, we don't see much, and he aspirated on top of that just for fun, but we don't see this appearance. Either we just don't image them that soon, or the treatment, when they get the disease, it's because they're often treated pretty aggressively early with voriconazole. We just don't ever get to that stage where they get that big. I don't know if I mean, I remember seeing this as a resident, David, but I don't see it much anymore. Do you guys still see this?
Yeah, we see aspergillus in our solid organ transplant patients. We also see nocardia and crypto. And what was his transplant? Did you say liver?
Liver. Yeah, I mean, so they reduced their immune suppression somewhat after a while. It's not nearly like lung.
That's
we occasionally see it, but it's just because they're all on voriconazole, we frequently don't see it, at least when they're heavily immune suppressed.
So, we saw a lot more of this 10 years ago. So somehow between the mid, 2000s and this decade, the rate of these transplant patients coming in with pulmonary nodules has decreased a lot. But we see, nocardia was a biggie. I think that was the most common one, followed by crypto and aspergillus. And the patients are usually asymptomatic. It was just part of screening radiographs that would detect these things. It has a much more indolent course than invasive aspergillus in the setting of stem cell transplant. Those people, this stuff really moves day by day, and these other nodules can sort of probably hang there for weeks without changing very much.
Okay.
Jeff, how are you making the diagnosis of these fungal infections? Meaning, how are you speciating out Aspergillus or Mucor or others? Because we've been having a lot of trouble, or our ID teams have, and we've been doing a lot more CT guided biopsies, especially in neutropenic patients.
They usually just get BAL and send it, send it off for fungal cultures, and they can get it. I don't know. Our lab seems to be really good at getting organisms when they're there.
They rely a lot on the DNA probe for sensitivity and stuff like that. So they don't always culture it, but they can get it on they're on the probe. But it can be very hard. So the Mucor cases in particular often are not diagnosed on lavage and do require a needle biopsy. And my notion is because the fungi are tissue invasive, they're not actually in the air spaces available to be washed out and into the hands of the bronchoscopist. So I think when these organisms are tissue invasive, they're harder to detect short of a invasive biopsy.
Yeah, we've had reasonable success with CT guided biopsies, and we probably are doing, I don't know, 1 or 2 a month specifically for trying to find fungal organisms in these suspected angioinvasive disease. I was just curious if anyone else is doing that.
We do it a fair amount.
Okay.
I'm just curious if Chris came up with the idea for doll eyes after playing with his well-impressed doll collection.
I like it. It's a great example. I just not heard that term.
It's actually really creepy. It reminds me of a horror movie or something.
Yeah. What's the name? Was it Chucky or something? A little.
Yeah.
Oh gosh. Okay. This is a nice case, and for all I know, I may have shown this case in the past, but now we have an additional diagnosis. So this is a patient with Sjogren's syndrome, and I've got 2016 and 2017, and you can see he has cystic lung disease with some soft tissue nodules. This is a pretty rampant case of LIP, lymphoid interstitial pneumonia. And, when we see these nodules, we think of lymphoid aggregates, amyloid, light chain, the whole thing that we've been talking about with these proteins. But of course, one of the things you also have to think about is lymphoproliferative disorders. And this dominant nodule here in the middle lobe got a lot bigger. No, I'd say a lot bigger, but it was growing, and it was growing kind of steadily over some scans. And so the question of lymphoma was raised. And so this was actually wedged out and was shown to be a malt lymphoma, which we see in Sjogren's syndrome. So it's just one of those things in this with Sjogren's, because we see a lot of nodules. Is exactly when do you pull the trigger on these, and do you follow them or not? Because they often have a lot of nodules. But this one was getting bigger, and I think it's because of its size. And it may be a low-grade lymphoma, but it's not something we talk. Most of the lymphomas in Sjogren's seem to be in the head and neck, but they can get pulmonary lymphoma. And I think, and David, correct me if I'm wrong, but early in the days of LIP, it was thought to be a precursor of lymphoma, and then subsequently it was shown really not to be. And I don't think it still is. I think it's because it's just a polyclonal lymphoproliferation, but because of the underlying Sjogren's syndrome, whatever's driving that autoimmunity, they are at risk of developing lymphoma separate from their LIP.
My notion is that they get a variety of lymphoid problems, one of which is lymphoma and the other is LIP. So there's a spectrum. Mm-hmm. And just because you have one doesn't mean you're not going to get the others.
Right.
As in your case.
So are you just following that one?
Well, they wedged it out, and it's lymphoma. Okay. So I don't know what to do with it if they're going to treat it, because sometimes they're so low grade. Yeah, and Chris just said there's another nodule growing in the left lower lobe. So whether it's multifocal maltoma, which it probably is.
Yeah.
Okay, so this is an unusual case because it's a gunshot wound. We don't see too many of these, although in the last year or two, it's kind of seen an increase. But you can see all the bullet fragments here. And that's not what's interesting. What's interesting is the imaging findings. So this is a young guy. I don't know why he got shot, but it's probably a gang-related thing. But you can see already there's some kind of injury here in the left hemithorax. He's got a pleural drain in. But I want you to follow these vessels in the anterior portion of the chest wall mediastinum, and you'll see there's this tangle down here. So now I'll just kind of follow them down for you. So if we start at the top, you'll see that the left internal thoracic or mammary artery is quite juicy. And as you follow it down, there's a couple branches coming off of it. And some of these branches eventually make their way into this area or right around this area of consolidated lung. And there's all these little collaterals here, and it goes into this dense area sort of near the lingula. There's also this big inferior phrenic artery coming up here. And then you can chase this back to this vessel here, and believe it or not, it actually connects to the left lower lobe pulmonary artery. So this is a systemic to pulmonary arterial fistula. Now the question was, is this gunshot induced or is this congenital? And when I first was shown this case, my initial impression was this was congenital given the size of these vessels. I mean, the fact that they would have just opened up that fast, I find a little hard to believe. I don't have any historical imaging, so I have no way to know for sure, certain. And that was kind of I think our consensus at the time. But it's just kind of funny that, I mean, there's injury right in that location. I don't know if you guys, I know you, Travis in particular, you've probably seen a lot more penetrating trauma. Have you seen a fistula this size, and I guess you too, Seth, develop in such a short period of time? I mean, he was transferred here, hours after the injury. So this is probably, less than 12 hours.
I think it's congenital. I mean, I have not seen the vessels dilate like that quickly. I showed a similar one from internal mammaries, 2 internal mammaries, the same thing in that same exact spot, draining into the left PA. So I think it's congenital.
That was our sort of our thought as well, and just happened to be where the injury is. But there you can see I made a MIP here. You can see the tangle of vessels. I mean, that huge draining pulmonary vein. Pulmonary artery there. So I thought that was cool. All right, and then I will show.
Brand, have you seen anything like that at Grady?
No, I've never seen anything like that was trauma-induced.
Yeah, Jeff, any notion that he'd been shot before?
Not to our knowledge. There were no bullet. It looks like it was all from the same bullet. All right, let me and I'll show one sort of companion case, and then if there's time, I have another one. It's a little bit more involved. So this is an 82-year-old man who just came to the ED with, I think, some chest pain or something. I just pulled this scan in particular. But you can see he's got this kind of fluid attenuation stuff in his pleura. And you might think this is loculated effusion. Turns out this thing has been there since, I think I went back to 97. I could find an old CT. And you see there's some calcifications in them with central lucencies, and then there's some coils here. And these coils have been there as far back as I can find the imaging of this guy. So this is a complex lymphatic malformation, but clearly there's a venous component because I think these are all phlebolysts as well. And there's some large bronchial arteries going to that right lung as well. And it's just, it's bizarre looking, but I think it's involving pleura primarily, and that's why it looks like loculated pleural fluid, because if you look on the lung windows, it's following the fissures and all the pleural, and it's got smooth interfaces with the lung. So I think it's a pleuromediastinal lymphatic, mixed, what I don't know what the terminology is, mixed malformation. And I don't know where the drainage is going in this thing, but clearly has some phlebolysis, maybe through some of these inferior phrenic vessels.
Well, I was just reading up on this, and sometimes these slow flow venous malformations can have a prominent and majority lymphatic component.
Okay.
I don't know if anyone else I was just reading up on this because the terminology always confuses me.
Right.
Like a few weeks ago, and I don't know if anyone else has heard that or.
Yeah, I mean, maybe a candidate. It's hard to know if this is just normal lung anatomy, but you've got some of the veins passing through this, and there's this small branch vein coming here to the left atrium. But I've seen one case that had a large vein that drained into the left atrium, actually presented with a stroke, but it was primarily mediastinal, but it was very similar. It was sort of mixed lymphatic, venous, but yeah, that was kind of odd. All right, well, I'll stop there. I've got some others if there's time, Travis.
Anybody else have things they want to show? I can show a couple more.
I have a quickie if
okay.
You guys want more entertainment here. So this case was sent by a former resident and fellow who moved to Hawaii, and he sent these three JPEGs of not a uniquely but concentrated Hawaiian disease here. So this fellow was tumbled in the surf, and see if I have more pictures of it here, and has this contrast CT here, which has these very dense branching structures throughout the right lung in the middle of all this consolidation here. And these are sand bronchograms. This fellow was rolled in the surf by a big wave and inhaled and aspirated a whole bunch of sand into his airway. So this bright material here is quartz. This is sand. These are sand bronchograms. So, you know, all is not right in Hawaii. So this is not a guy, it's a female here, I think you can see. But, you know, it's nice to go to the beach, but be careful, guys.
Didn't you show
David,
one of these a couple of years ago?
Occupational lung disease if you're a professional surfer?
I don't think this is the physique of a professional surfer here. This is not occupational lung disease. This is not silicosis that you're going to get compensated for.
David, didn't you show one of these before?
I don't think
ago?
I've wanted to, but I don't, unless I've showed this case, I've not shown this before.
I thought somebody has. Yeah, that's now. Did they go in and try and bronch and lavage her, or what do they do?
You know, our former resident and fellow here was not the most verbal guy, so he didn't actually provide a whole lot of history. Here's what the radiograph looked like. So I really don't know what the upshot of this was, but sand bronchograms.
That's impressive. All right.
Crazy.
I'm going to show a couple more and then we'll go back to Jeff. Let's see. Get back to my screen here. All right. This one should be equally entertaining, I think. And want to maintain a professional air as we discuss this case. But this is a guy who came in and he had 6 days of shortness of breath, and it started to get better, but then didn't really get better. And you can see he has very symmetric peripheral ground glass opacities, a little bit of consolidation, maybe a little bit of atelectasis mixed in there too, in the lower lobes in particular. It's kind of interesting, though, that this is more upper lobe, at least the ground glass is, because this is hematogenous spread of something. And we've seen this before, but not quite in this exact mechanism. But this is silicone embolization syndrome. And, you know, Jeff, I was thinking back to your talk in Australia and just talking, I guess it's Galvin's, some of Jeff Galvin's stuff, just talking about hematogenous spread and how we think about lower lobe predominant findings. But it is kind of interesting. And I don't know if it was that he was supine when he injected, but this guy, the history was that, let's see, ignore that. See if I can.
So Travis, this is an intentional injection?
This is an intentional injection, and I'll just let you read here. So 6 days of shortness of breath. 7 days ago, he was injecting what he calls medical grade silicone into his penis for cosmetic reasons. And this is the first time he apparently had hit a vein causing bleeding. And then he developed chest pain and shortness of breath a few hours later and came in with that. He said he's been doing this for a year and a half, never had symptoms similar to this. So this is, I guess, another place that people can inject for cosmetic reasons. But yeah, this was an intentional, injection. So I just don't know. I mean, it kind of looks like fat emboli, like some of the other cases we've seen. He didn't have any right heart strain or any findings like of severe acute right heart issue. And I think it's probably just because it was a fairly small amount that intravasated into a vein and ended up in his lung. But this was just another cause of silicone embolization syndrome. But I'm curious what you guys think about the distribution.
Yeah. Do you have coronals? Can you show us on the coronal?
Yeah, we can see. It's like, especially more anteriorly, it's much more in the upper lobes. It's not, without a history, there's no way to know this.
Eosinophilic reaction.
Maybe taken out as lower lobe vessels. Actually, are the lower lobe vessels, well, some of them are pretty good. You wonder if he's been doing this for some time, if he's been microembolizing to his lower lobes and has slowly taken them out.
Yeah.
So there's more blood flow going north.
Yeah, I don't know.
Look pretty healthy, though.
Yeah.
And he doesn't have pulmonary hypertension.
No, he doesn't. His pulmonary artery looks fine. His right heart wasn't really dilated. You know, of course, that's, as you point out, David, that's the risk that, you know, these patients often die from if they, you know, in these embolic phenomena, right heart issues. But I don't know. So another case of silicone embolization syndrome, just a little bit more mild.
I mean, were the results worth it? You didn't comment on that.
I don't know. Oh, there's a question. What's the cause of the lung findings? Is it organizing pneumonia from silicone? It's more, I mean, the ground glass at least is a chemical pneumonitis that these patients get, just like amniotic fluid or fat emboli. At least that's my understanding. And maybe this is a little bit of organizing pneumonia here. That's a good question, especially since it's been a few days. But the other question that came up when we were discussing this in the reading room with the POEM team is just, you know, does this stuff clear? And I don't know if it ever clears further than the lymphatics, because you know, when you free inject silicone into other places, you can see it as those well-defined little silicone like granulomas or whatever, the little walled off areas of fat and calcification. So
yeah, so it's probably, I mean, it's probably microemboli causing infarcts, and then the organization as a response to the infarcts.
Yeah.
Right. I mean, it's okay.
I guess, yeah. So
what was the time frame of the CT relative to the injection?
7 days.
7 days. Okay.
His symptoms had started a few hours beyond the injection, but this was 7 days after when he finally came to the ED.
Okay.
So, yeah. All right. Well, that's my other interesting case for the week, courtesy of Brett Elliker. So I'm going to make Jeff presenter now.
Okay, I've got those. I got two of the Niemann-Pick cases I can show. All right, you guys see a Röntgengram?
Yep.
So you can see this is an older patient. This is an old case from 2001, 2003, and you've got, you know, heart surgery, et cetera. But, you know, you might be inclined to call this fibrosis or edema in this setting if you didn't know what was going on. But you'll notice there's no pleural effusion. It almost looks like there's some reticulation. But here's the CT scan. This is one from 2005, and you can see there's septal thickening, some areas of crazy paving, a lot of ground glass, and some spared lobules, just like yours had, Travis, interestingly. And you wonder why some get spared, I think. And then I've got an older scan from 2002.
Jeff, was it an aortic valve replacement that they underwent, or was this coronary bypass grafting?
It was an AVR, and yeah, that's what it looked like. And so you see, it looked exactly like that beforehand. It's still no pleural effusion, and then there was this is just some other images. I think those were attempts at expiratory images, but some air trapping. You wonder if the air trapping is actually related to old histoplasmosis, because there seems to be a calcified nodule associated with a lot of them. And sometimes I've seen this where the granuloma, whatever you want to call it, the granulomatous area of inflammation, takes out a small airway, and you get lobular air trapping, because there's another one there. But this was one Niemann-Pick. So
Jeff, did the Niemann-Pick people get did they get amyloidosis from the deposited protein? Because
not
those,
to my knowledge, I always forget what it is. It's like sphingomyelin or something. So it's a fatty substance. So no.
Yeah, it's sphingomyelin, and it accumulates in macrophages.
This may actually be the same patient. Yeah, that's the same patient. The other one didn't download. Yeah, I think we have time. This is a fascinating case my colleague Chris Francois shared with me. Now, hopefully it won't crash the system. I won't show everything, but this is I don't know if you guys do any PET, cardiac PET, but this is an FDG PET of a patient who has sarcoidosis. And it's nice because I also have the cardiac MR and the FDG image. So these are the FDG images here. And they, I've included in the case, there's a special prep for this because they have to put them on a no carbohydrate, high fat protein diet for a few days to kind of flush it out. Because, you know, normally the left ventricle takes up a ton of FDG. And in this case, you can see this is there. I have 3 different time points here. And so this is following treatment. This is baseline. This is I don't remember the dates on these exactly, but these are serial. So going from presentation to most recent. And you can see at the presentation there was some FDG uptake in the septum, also in the right ventricle. There's the fused images, the PET images, and with treatment, the amount of FDG uptake diminishes and then becomes sort of normalized. Now I can show you the cardiac MR as well. There was a CT, and it's a very subtle finding. I can't remember. I don't think it was done here, but when I looked at the CT, I'm knowing that the patient had sarcoid. I did kind of look in the typical areas, and you can see there's some nodules along the bronchovascular bundles, but it's a very subtle appearance of sarcoid. But if you look, you can find findings that support of sarcoid in the lungs. But the amount of lung disease was mild. Let me see. I want to find the post contrast in here somewhere. This might be it. Yeah. Let's see. Yeah, here you can see the delayed enhancement images here. You see there's some subendocardial sparing. You've got some in the left ventricle. Here in the intraventricular septum, you see some nulled myocardium on both sides, but sort of mid-myocardial in typical locations of it as well. And that corresponds nicely with the FDG images where we saw that in the intraventricular septum. So I've included all the PET images, but we don't typically see a lot. Thought I had one more that had the MR fused with it as well, but I don't. But yeah, so it's something we don't see a lot. Here's some more in areas of that. You can see that signal abnormality in the ventricular wall. So I don't know, Travis and Seth, are you guys doing cardiac PETs at all?
So in Maryland, they were only doing cardiac PETs for sarcoid because it's supposedly more sensitive and specific. So all our sarcoid patients automatically got a PET and not an MR.
Okay. Yeah, and here are the MIPS. I think this is a great example of MIPS really bringing out the perilymphatic nodules that, especially to a less experienced person, might walk right by on a chest CT because they're not rip roaring on the standard images, but you can really see them clustering. And I think she presented with arrhythmias, maybe a cardiac arrest. She has a defibrillator in and all that. But yeah, I'll send it all together, and you can look through all the images. There's a bunch of fused images and stuff like that as well. But I thought the prep was kind of
doing PET to look for active nodes in sarcoid, because we've been doing some.
No, because
just for disease activity in general.
I haven't seen that as a routine. It would make sense, but so you're saying to follow response to therapy?
Yeah.
It would make sense. We haven't done it.
Yeah, I mean, I guess there's some recent literature. I'm not as familiar with it, but one of our sarcoid pulmonologists likes to order them. Of course, we're not reading, the nuclear medicine folks are reading those, but I was just curious if anybody else is doing that as an emerging trend.
We have not been, as far as I know. Okay.
All right, should we stop there? It's about 1 o'clock.
Well, thanks, Travis, for starting the conference today.
Yeah, thanks, guys. Good cases.
We had a visiting speaker we were meeting with. So.
All right.
Take care, guys.
See everybody later. Bye-bye.